the definition that we have is gas enters the pleural space and separates the visceral and the parietal pleura. So that's our definition when it comes to pneumothorax. For a simpler term, it is air in the pleural space. That is not supposed to be there, right? So if I start to get air in the pleural space, it's going to start to compress everything that is inside the visceral pleura. So the alveoli get compressed. That compression leads to atelectasis. You'll have unilateral chest expansion. That can lead to a increased pressure, intrathoracic pressure, that starts to squeeze on the mediastinum. In the mediastinum, we have the heart and we have the great vessels. All of those things are very, very important. If those have a bunch of pressure on them, if my heart has a bunch of pressure on it, does it have the ability to expand and contract? Expand and contract. Not if the pressure is great enough. So if I don't have enough room for that heart to expand and contract, it's going to decrease the amount of blood that's coming back to the heart because I'm not pumping blood around the body. So we get a decrease in venous return. We'll learn that there is an arrhythmia that's associated with this because the heart is still getting the electrical activity to signal for it to beat. It's still getting the signal to the SA node or the AV node. It's still getting those signals, but it has no room for expansion and contraction. That is going to be an arrhythmia. That's a deadly arrhythmia if it's not fixed very, very quickly. So we need to be aware of and we need to identify these pneumothoraces, especially if it's a tension pneumothorax. And we'll talk about a tension pneumothorax here in just a second. But when we look at the etiology, what this is talking about is what's the origin? Where does it come from, right? So we can get air in the pleural space from the lungs through the visceral pleura. So if I have some sort of leak from the lungs through the visceral pleura, that can lead to air getting into the pleural space. So all the air that I'm breathing in should stay within my system of my lungs. But if I have a puncture or a let's just call it a puncture. If I have a puncture in my lung parenchyma, that will lead to air escaping the lungs in that circuit and moving into the pleural space. We can get a perforation of the chest wall and the parietal pleura. Remember, visceral pleura is around the vital organs and the parietal pleura is on the perimeter. So this could be a chest wall injury. Remember, we talked about the flail chest and how if it's not a clean break, it creates these jagged, sharp ribs. Well, if that nicks or scratches or scrapes the parietal pleura, now I have an opening from the atmosphere into the pleural space. Other ways that we can get air into the pleural space through the chest wall and the parietal pleura is an esophageal fistula or through the abdomen. So these are holes in the esophagus or in the abdominal lining or the viscus, the abdominal lining that gets or moves air into the pleural space. The last one that we see here, it's quite rare and it's associated with empyema. Empyema is pus in the pleural space. So we'll talk about pleural effusions. Empyema is a form of a pleural effusion. And these are rare, but you do have some gas-forming microorganisms within empyemas that produce gas that will then lead to air in the pleural space that way. So those are that's kind of the overview definitions, what to expect, and etiology when it comes to the pneumothorax. Now, pathophysiology that's associated with that is we're going to get lung collapse. Lung collapse is going to lead to atelectasis, and you're going to have an increase in the chest wall expansion if this is not fixed. If this is not fixed, then you have a lot of air going into the pleural space, which leads to almost like a barrel chesting of their anatomy, and it can lead to a compression of the great vessels. If we have the compression, that will lead to a decreased venous return, which then leads to more issues down the line. So let's get into some of the classifications of pneumothoraces or pneumothorax. So generally you have kind of two schools of thought when it comes to classifying a pneumothorax. It is closed, open, or tension, or you can have traumatic, spontaneous, or iatrogenic. So they're both kind of their own school of thought when it comes to classifications, and we're going to talk about each of them. So when we talk about open, this is when the pleural space is in direct contact with the atmosphere, and gas can move freely in and out of the pleural space. So if I were to look here, see how I have a puncture through the ribs into the pleural space, I have this opening of air that can move into the pleural space, and it can move freely out. So this is what we call an open pneumothorax. When we look at a closed pneumothorax, gas in the pleural space is not in direct contact with the atmosphere. So if I look here, I have a puncture in my visceral pleura. I have a puncture in my visceral pleura, and I have air that's coming in through the airways and escaping into the pleural space through the visceral pleura. So this would be an example of a closed pneumothorax. Then we have what's called a tension pneumothorax, and the intrapleural pressure exceeds the intraalveolar or the atmospheric pressure. So in these, we have air that's moving in, but then whenever we go to breathe out, see this little flap that's right here from the trauma? Whenever I go to breathe out, that flap occludes the escape port, the entry site, right? So we get air that moves in, and then whenever I go to breathe out, it's like this latch closes and the door is shut, and all of that air is trapped here in the pleural space. So when that happens, it starts to put a lot of pressure here in the intrathoracic cavity. And that pressure that's in the intrathoracic cavity is greater than what's in the atmosphere. That leads to more compression of the mediastinum, more compression of the great vessels, more compression of the heart. What do you think? So if we decrease venous return, and I decrease the amount of pressure each time I pump, it leads to a decrease in that blood pressure as a result of just the heart not being able to squeeze and contract the way it's supposed to. So let's look at the traumatic, spontaneous, and iatrogenic now. But we have to understand that the open is open to the atmosphere. Your pleural cavity is open to the atmosphere. Closed is it's closed to the atmosphere. And lastly, we have this tension pneumothorax where we have air coming in, but it has no place to go once it's in there. So 3 different classifications. We're going to now jump into traumatic, spontaneous, and iatrogenic. So when we talk about traumatic injuries, this could be a penetrating wound to the chest, whether it's a knife or a bullet or some sort of impaling object. This could be getting stabbed between the ribs and it puncturing the parietal pleura. Could be an example. But the pleural space is in direct contact with the atmosphere. Sounds very similar to the open pneumothorax. Gas can move in and out of the pleural space freely, and you have what's called a sucking chest wall wound, or a sucking chest wound is another way to look at that traumatic pneumothorax. or even calling it an open pneumothorax. You can have a piercing chest wound, which leads this closed or valvular or tension pneumothorax. So this one-way valve that we talked about with the tension right here, again, air comes in from the atmosphere, gets into the pleural space, gets into the pleural space, and then whenever you go to exhale, that one-way valve closes and there's no escape hatch. There's nowhere for the air to go. This leads to a lot of issues. So the parietal pleura or the chest wall act like a one-way valve where you get gas that enters the pleural space during inspiration but cannot escape during exhalation. The intrapleural pressure exceeds the atmospheric pressure. That sounds very similar to the tension pneumothorax. In fact, it's the exact same verbiage that we used for the tension pneumothorax. This is the most serious of all of the pneumothoraces because gas continues to accumulate in the intrapleural space, and you get a progressively increase of compression pressures on the lungs and the structures in the mediastinum. Again, you have your great vessels, you have your heart, you have your descending aorta that goes through this. Lots of compression on those major vessels and the heart, which can cause what we call, it's a form of cardiac arrest. It's called pulseless electrical activity, or PEA. Whenever we go through ACLS, we will get way more familiar with PEA. But just know that the heart is still getting signals to pump. It just does not have the capacity to expand and contract, So a crush injury, the pleural space may not be in direct contact with the atmosphere. So the pleural space may not be in direct contact with the atmosphere. This can be more of this situation. The sharp end of a fractured rib may pierce or tear the visceral pleura. That's what we've been talking about since the flail chest little snippet. And gas then leaks into the pleural space. So you get air that is coming in because it punctured this visceral pleura, and now you have air moving into the pleural space and does not have an area to escape. The next form of a pneumothorax that we're going to talk about is the spontaneous. It's the spontaneous pneumo. So this occurs suddenly and without obvious underlying cause. A good friend of mine has had this happen to him twice, and it's led him to be in the hospital both times. And this is secondary to an underlying pathological process, whether this is a history of pneumonia, tuberculosis, COPD. But essentially what happens is there's a bleb, and a bleb is like a stretched out part of the lung. So when we overdistend a balloon, you get little spots of weakness, and you can kind of see where it's gotten thin. And right where that is, that's what's called a bleb or a bulla. Anyways, that's a thinning of the lung parenchyma and an increase in pressure or an increase in volume. So they just take a big deep breath to do a squat, or they take a big deep breath because they yawned or because they coughed. Well, that increase in volume or increase in pressure is going to lead to that thin spot rupturing. And now you have a closed pneumothorax situation. But that small rupture of a bleb or a bullae on the surface of the lung is what happens with these spontaneous pneumothoraces. This typically happens with tall, thin people that are aged somewhere between 15 and 35 years of age. This is something that even Abe Lincoln, I believe, struggled with. Patients that have Marfan syndrome are another patients that are at risk of this. And what ends up happening is there's a high negative intrathoracic pressure and mechanical stresses on the apices that lead to a tension pneumothorax, or it behaves very similarly to a tension pneumothorax. The last one that we're going to look at here is an iatrogenic pneumothorax. Say that word again. Iatrogenic pneumothorax. What this means is it's a pneumothorax that occurs during a diagnostic or a therapeutic procedure. So let me ask you, what procedures have we talked about so far in this program that would lead or could cause a pneumothorax? Well, it could be a pleural or liver biopsy. It could be a transthoracic needle biopsy. So biopsies that are near the lung parenchyma are some of the typical things that we've seen. A thoracentesis. So patient has a pleural effusion that's being drained. What if the needle doesn't stay in the pleural space and it punctures the visceral pleura? Could be that a thoracentesis would cause a iatrogenic pneumothorax. Intercostal nerve blocks, we don't have those. There's only certain areas that allow the respiratory therapist to do those nerve blocks. But this is something that happens in anesthesia and in the OR. So that could be something that we want to just be aware of, especially when a patient's going into surgery and they're having this intercostal nerve block as part of the procedure. You can have a central venous catheter placement, whether it's in the internal jugular vein or more commonly the subclavian vein. Either one of those, the lung parenchyma is sitting very close to, if not underneath, the puncture zone for those procedures. You can have a tracheostomy or even a bronchoscopy with biopsies, but those are a little bit more rare. And we always have a risk for these iatrogenic pneumothoraces when we are doing positive pressure ventilation, whether that's non-invasive or invasive with mechanical ventilation. This is something that we have to be aware of, especially if we're using tidal volumes that are really large or using pressures that are really large. And even more especially if that patient has a history of COPD, HIV, or ARDS, acute respiratory distress syndrome. So with all three of those conditions, their compliance is no bueno, meaning it is really stiff lungs, meaning it takes a lot of pressure just to receive just a little bit of volume. So those patients would be more at risk for a iatrogenic pneumothorax, and we need to be on guard. It is our responsibility for that. All right, so we are going to start looking at more of the symptoms. Let's talk about what this patient is going to present like. So the clinical manifestations, how is this patient going to present? And then we'll start looking at the signs here in just a second. So one of the things that we can recognize and we identify when it comes to a pneumothorax is this sudden onset, sudden crisis onset. I want you guys to circle this, highlight this, star this, because most of the time, a pneumothorax is going to be a sudden onset. Now, if you have a patient that has that empyema and they have that bacteria producing different gases, then that will be more of a slow developing. But like it says down here, like I said, it is a rarity that you have a slow developing pneumothorax. Most likely you're going to have that sudden crisis onset. So if I were to look at this and I were to evaluate a patient for a pneumothorax, if it is one that is slow developing, I would think more of the empyema and the bacteria that produces gases more so than something that is a sudden onset. You're going to have shortness of breath. You're going to have pleuritic chest pain. You're going to have dyspnea. The patient's going to present with a cough. You may start to see their blood pressure tend to trend down, and their heart rate is going to start to go up just to compensate for the low blood pressure. One of the other ones that you might see is hemoptysis. This is a not very often. symptom of pneumothorax, and this hemoptysis is not life-threatening like some of the others that we might see in the future. So our initial symptoms when it comes to a pneumothorax. When we look at our vital signs, what's our vital signs going to be? We already talked about blood pressure. Blood pressure is going to start to decrease. Again, you have a decrease in venous return. You have an increase in intrathoracic pressure causing cardiovascular collapse. So the blood pressure is going to go down. How is the body going to respond to the blood pressure going down? Well, the heart rate's going to go up just to try to maintain that patient's cardiac output. So blood pressure down, heart rate goes up. How well is this patient going to be oxygenating? Look at this patient's face. Do they look like they're oxygenating very well? Do they look like they will be oxygenating very well? Especially if this starts to lead to alveolar collapse and atelectasis. I don't think so. So when you have a decrease in oxygen, what happens to your respiratory rate? Your physiologic response to hypoxemia is going to be an increased respiratory rate and an increased heart rate. So your heart rate starts to